Okay, hi everyone. I think everybody is in now. First of all, I'd like to thank everybody for coming to what should be a very informative webinar. I, for one, am very excited to hear from our speakers that we've got lined up today. And why are we talking about alcohol? The last few years have seen many changes around alcohol and alcohol drinking habits. Minimum unit pricing came into Wales in late 2019 and Scotland in 2018. And this means that alcohol can be sold for currently at least 50 pence per unit. And the hope was for this to limit or reduce the amount of alcohol individuals drink. But the full impact of these changes are not fully yet understood, as early in 2020, as we all know, COVID and lockdowns happened. So according to the Office of National Statistics, there were 7,423 deaths from alcohol misuse in England and Wales in 2020, and 80% of those were from alcohol-related liver disease, which is an absolute tragedy as those deaths could have been prevented. But liver disease is the third leading cause of premature death. And there's some anecdotal evidence that COVID has had a dramatic effect on end-stage liver presentations in hospital, reduced surveillance on the less ill, and difficulties in accessing healthcare support and greater difficulties in obtaining referrals. Also, some groups of people have seen a dramatic increase in the intake of alcohol. Support services are struggling, including alcohol support services, mental health and counselling, and this problem is increasing. As we know, there's a strong link between mental health and counselling and alcohol. So anxiety and depression for some people may have increased over lockdown, and there may be some pressures related to returning to normal as things open up. For example, sober shaming. So you can see this is a very complex issue. We're going to move on now to the main parts of the webinar, where hopefully some of these issues will become a little clearer. And please, if you have any questions, if you could pop them into the Q&A box, and we'll endeavour to answer as many as we can at the end of this session. Thank you. Okay, over to Dr. Ian Rees, the gastroenterology consultant and Halva Health Board, and he'll be talking to us about what liver disease looks like and what you can do about it. Over to you, Dr. Rees.
So, as we're talking about alcohol-related liver disease, how does it come to light? Well, the most common thing to say is very often it does not come to light, and most people with alcohol-related liver disease we don't even know about. We can guess because they may be drinking excessively, but very often nothing is known. Just come up from the ward now with a 52-year-old chap who's been drinking very heavily. Now he's suddenly turned yellow and got ascites, so it's a bit obvious now, but maybe a year or so ago it may not have been quite so obvious. So often we get these people pitching up with abnormal imaging or abnormal blood tests when they've had stuff for other things. Some people present, as my man I've just described, very unwell with things like alcoholic hepatitis, liver failure, and then the complications of liver cirrhosis, such as bleeding and ascites and all that horrible stuff. But I think, I've gone the wrong way now. So this is the biggest thing that I try to label, especially to GPs and to other healthcare professionals, is that the liver is not a particularly painful organ. The biliary tree is. So if you've got gallstones, and that's painful, and sometimes acute hepatitis can be a bit uncomfortable. But most liver disease is asymptomatic, very little in the signs and symptoms for a very long time. But you can have quite significant inflammation of the liver, which can lead to scarring with no real signs. And it's not uncommon for people to present with cirrhosis and liver failure as the first presentation. So I'm sure you'll all be aware that there's an All Wales liver delivery plan. And that's the aim of that in many ways, or one of its aims, is early identification of liver disease, because it's far easier to prevent, well, it's not easy, but it's far more enjoyable to prevent liver disease than it is to pick up the pieces. And so this pictorial thing, most liver talks will have something like this. Most of us hopefully have a liver in the left-hand side of the picture. If we drink too much or eat too much, we can get a fatty liver, and those two things are perfectly reversible. Then a certain number of people then go on to continue to insult the liver, will go on to get scarring, and that's probably reversible. And then, as it stands now, a certain proportion of those will go on to get cirrhosis, which, as we stand today, is probably an irreversible state. That, of course, may change with treatment developments in the future. But once you become cirrhotic, then you're open to all the complications such as bleeding and ascites and encephalopathy and all the horrible other things. So the thing to labour really is that most people with quite significant liver disease probably do not have any symptoms and probably aren't known to anybody in the healthcare professional. It may become obvious when something happens, they decompensate, or they come into hospital with a chest infection and then stop drinking, get alcohol withdrawal. So this is a very common reason for referral to our clinics. There's a chance finding that someone will have quite often a kidney stone. The kidney doctors will arrange a CT, and the CT shows a cirrhotic liver, or someone has some vague abdominal discomfort, has an ultrasound, and it becomes obvious. Or the GP does some routine bloods because the patient has diabetes or high blood pressure, and they notice the liver tests are abnormal. And then part of the liver plan is to try and encourage people to be alert to this, really. I'll just touch basically on some of the more obvious presentations. I mean, this presentation was more towards medical students. There are some people who become obviously totally unwell, become yellow, jaundiced, and bloated and unwell, and it's all fairly obvious then. So when people present with very inflamed livers, a condition known as alcoholic hepatitis, you'll note I never use the term alcoholic unless I use the word alcoholic hepatitis. It'd be nice to change that name to alcohol-related hepatitis also, but I think we're stuck with it for now. I'm not going to dwell on this unless someone's got a particular want to go over alcoholic hepatitis. The other thing that we do then see is that probably the commonest way that they come to hospital or to clinic is they decompensate. The liver that is working well, despite being very, very damaged, then ceases to work well. And then you get all the organ dysfunction. So you go yellow, you retain fluid, you've got a risk of infection and bleeding. And this is what we see quite often in the hospital. And what I would draw your attention to, and I spoke to a very senior nurse the other day who hadn't appreciated this, that the outcome in any of these presentations is death in 50% of people in 2 years. So if you become so unwell that you present with yellowness, your chances of being dead in 2 years are 50%. And that's quite shocking. So that's why it's very nice to intervene early doors with alcohol so that people don't get to these places. We always never assume alcohol. So from the point of view of us as clinicians, whenever we see someone with liver disease, we always check for everything else because it's not uncommon that people have cofactors. So alpha-1 antitrypsin deficiency, quite common in the Llanelli and Ammanford area. Hemochromatosis, there's an excess of iron. These are not uncommon things. And in certain populations, although less so now, with viral hepatitis, people involved in drugs don't seem to drink as much, really, so that the crossover, I don't see that much. But it's always worth checking for these things and not making any assumptions. Of course, once you get the cirrhosis and the damage to the liver, the presentations and the problems become more difficult with bleeding and fluid and poor nutrition and things like that. But I don't want to dwell too much on the clinical side, but from our point of view, getting a good history, talking to relatives, looking for clues on the examination, always being alert to alcohol withdrawal, and nutrition is vital, and always thinking about thiamine replacement, because we've had quite a few youngsters in their 50s who've developed brain-related thiamine deficiency, and that leads to long-term, short-term memory loss. That's the wrong way to say it. It leads to short-term memory loss that lasts. You know what I mean. Alcohol withdrawal, I'm probably not going to talk hugely about that. In the hospital, we use the CUR protocol. I'm slightly embarrassed because I nicked Nicola's slides for this, so she's probably cursing me at the other end of a muted screen. So I'm conscious of my time here. So what are we going to do about it? I mean, we know what liver disease looks like. The strategy is, how do we reduce it? How do we work with a liver disease implementation group to reduce it? I think identification of any liver disease early is vital, because if you can treat someone's hepatitis or their alcohol-related liver disease, whatever it is, then it reduces the risks of progression to significant liver disease. The problem, of course, we face, like lots of things, is that most liver disease is asymptomatic until they present. And so we have to be alert to people's activity and their behavior. We often find missed opportunities. People who present a casualty with having been fighting or having fallen, and clearly alcohol has played a role in that, and these are missed opportunities to try and intervene. And so part of what we're trying to do is to actively search based on screening for alcohol and on the history of why someone's presented. And there's, as you know, all of you know, there's clearly good evidence that alcohol brief intervention is particularly effective and obviously quite cheap. So in Hywel Dda, the approach that we are hoping to adopt, although it is tricky, is that all patients who come into contact with the hospital sites have a screening questionnaire. These are people who come in for a planned admission, or those who present to A&E, or those who come as an emergency admissions. We use a modified Audit C thing, which is on the next slide, and all staff who are admitting have been trained to deliver this and to deliver alcohol brief intervention. Those, obviously, most people then can be referred on to the alcohol liaison service, and then the alcohol liaison service will decide who needs referral onto hepatology, or whether they need further assessment and risk stratification, and obviously onward referral to services such as CDAT and DDAS being the main port of entry. So again, I'm not sure who the audience is because I can't see you, but I suspect many of you will recognize this. If none of you recognize this, this is the audit tool. Fairly straightforward. The higher you score, the worse it is. So going back to primary care now, I don't know if there's any primary care colleagues on the line. There is a new approach launched now, looking at abnormal liver tests. I would counsel that many people with significant liver disease have normal liver tests, and many people with abnormal liver tests have no significant liver disease, so they're just a tool. I do see that some colleagues are very obsessed with gamma GT, and I would counsel against that. It's a very non-specific test. So a new approach looking at abnormal liver tests has been launched as we speak under the care of the liver disease implementation group, and education and raising awareness is vital. From our point of view, long-term follow-up, those with low scores and have an alcohol brief intervention and a follow-up call. Those with higher scores may be seen by the alcohol liaison nurses. The truth is the alcohol liaison nurses probably got involved in both of those. Referral to community service via DDAS, and those with quite significant liver disease, as either deemed by bloods or scans, will need follow-up with us so that we can avoid further complications. Our screening tool for deciding who's got a bad liver and who's got a good liver is generally the FibroScan. Again, I would counsel colleagues not to just rely on that. It is one test of many, and it can change, but it's a very useful tool. So I'm not sure if I've kept within my time frame, Sarah, but I galloped through that. So I've lost, I'll leave it there if I may.
Yep, that's absolutely perfect. Thank you, Dr. Rees. That was actually really very interesting.
You sound surprised, Sarah.
No, not at all. I knew it would be.
I do try.
I knew it would be.
Right, I'll go to mute now.
Thank you. Thanks very much. So if anybody has any questions, please pop them in the question and answer box. Dr. Rees isn't able to stay with us as he's very busy, as everybody is. But if there's any questions that we're not able to answer in his absence, we will follow up on that. Next, we've got Dr. Gareth Morgan, the Strategic Partnership Manager, and Nicola Reeve, Clinical Nurse Specialist from Hywel Dda Health Board. And they're going to be talking to us about the data around these issues. Over to you both.
Well, thank you very much and for that introduction, and good afternoon everybody who's joined this call today. And Anna Cymraeg, Prynawn da Pobl, and nice i weld ti. It's good to see everybody on this call this afternoon, and really appreciate the opportunity to give a paper in the next 10 minutes or so that my colleague Nicola Reeve will join me on, and I'll take the first few slides, and then we'll introduce Nicola to conclude the talk. Just to clarify, my background is actually public health, so my doctorate is non-medical, as opposed to Dr. Rees working in the clinical field. And I'd really like to start by reiterating some of his points about alcohol generally, and this fits broadly within the sort of canvas of alcohol policy. Alcohol causes massive problems, and as public health practitioners, we think about those broader issues. And I know the focus today, and rightly so, on liver disease, but it's worth just setting out that contextual issue as well, and my agreement with Dr. Rees's presentation. So if I could have the next slide there, please, Amy. And really just to set the context about this talk that we're about to hear, particularly from Nicola later, is about Hywel Dda University Health Board itself. This is sited in the Southwest Wales area and is one of the 7 health boards in Wales. So we have an NHS in Wales, and there are 7 health boards and some other trusts as well. And Hywel Dda is one of the 7 delivery trusts that work within Wales. And we serve a population of approximately 375,000 individuals, although we cover about 1/3 of the landmass of Wales. So we cover about 1/10 of the Welsh population and 1/3 of the landmass. So you can get a feel for the demographics of the area. We cover 3 local authorities. So these are the counties of Carmarthenshire, Ceredigion and Pembrokeshire. Carmarthenshire is the largest county that we serve, about 50% of the population. Ceredigion is the smallest of the counties, about 20% of our population, and the balance of the population, about 30%, is in Pembrokeshire. So just in terms of the actual infrastructure, in terms of the delivery of our service, the county of Carmarthenshire, the largest one, we've got 2 main hospitals there in the large towns. So if you know your geography, Llanelli, we've got Prince Philip Hospital, and in Carmarthen, we have actually West Wales General Hospital. The smallest county, Ceredigion, in the town of Aberystwyth, we've got Bronglais General Hospital. And then in Pembrokeshire, we've got a hospital in the town of Haverfordwest, which is Withybush General Hospital. And it's just worth setting that context. It'll make a lot of sense as we come to the rest of the talk. And if I could have the next slide, please, Amy. So in terms of service provision, each of these hospitals has an alcohol liaison nurse service. And the staff also work with patients with other liver diseases from other causes. And we've heard some of those from Dr. Rees, such as blood-borne viruses. And the demand from patients with alcohol-related liver disease has been particularly high since the lockdown associated with the COVID-19 pandemic, with caseloads rising steadily. And just the hypothesis for that is that lockdown created additional stress, whether that's financial stress, psychological stress, all kinds of factors. And for some heavy drinkers, the alcohol intake actually increased. And within Wales, as was mentioned in the introduction, we have the minimum unit price. So we're yet to see the full impact of that. In fact, they were very close in terms of timeline. So March 23rd last year was the date of the national lockdown, and the minimum unit price policy for Wales came in slightly before that. So we've yet to see that have a fair chance, really. It's been unprecedented times in terms of that. If I could have the next slide, please, Amy, and I'll bring Nicola in shortly, but I just want to allow Nicola to come in by introducing this slide. And as you can imagine, the service impact has been quite considerable associated with the COVID pandemic. Increased demand, and already the service was under pressure. And so we've needed to make some difficult choices around how we target that capacity, and obviously some very high workloads for staff who work part-time hours. And what we tried to do as a health board is to essentially respond to that. And in the short term, we've actually increased some of the staff hours. So if I can, at this point, pass the baton over to you, Nicola, to come in, and perhaps you could continue the narrative in terms of the service impact. Okay, we've just had a post that the mic won't come on. So what I'll do is I'll continue with the presentation of the slides. And if I can invite Nicola to put any comments in the chat bar, that might flesh out my comments. So as I was saying, we've obviously experienced the consequences of the COVID-19 pandemic, high workload for staff who deliver these services. What we've needed to do is to ensure the sustainability of that service. So as a health board, we have put in that initial response, and we've actually increased staff time as a first measure. So it is only a first measure to maintain that service delivery. And as we move forward, I don't think we've seen the full consequences of the COVID pandemic. As we move forward, naturally, we've got to keep under review the service capacity to ensure that sustainability, because I think that the correct assumption, the correct planning assumption has to be that we're going to get further demand on our service, and we want to respond to that further need. And clearly there will need to be further discussions around that within the health board. Amy, could I ask you to go to the next slide, please? So just a further consideration here, and Dr. Rees touched upon this last time, that you can actually have coexisting risk factors, and Dr. Rees mentioned about the local substance misuse services that we see in this part of the world. It's Dyfed Drug and Alcohol Service is one of the key providers. What we also noticed during the pandemic was a reduction in the uptake of needle exchange kit. So for those people that do take substances, obviously some of that might be through injecting needles and syringes, and there's a needle syringe exchange service. And there was a reduction of this during the lockdown of approximately a third. So we don't really understand what's happened there, whether it was purely a logistical thing or whether there was unsafe injecting practices and so on. But what we are anticipating with that is potentially a rise in the amount of bloodborne viruses in the community. Now, this does link to alcohol misuse because clearly some patients will also be drinking, as we've experienced through the pandemic. And what we could find is a very high risk group of individuals who could develop liver disease because they have multiple risk factors. And as Dr. Rees was saying, that risk might be small, it might be a low number, but their actual risk of illness could be quite considerably high. So that's something that we've also got to factor into our planning assumptions as we move forward. Amy, could I invite you to put up my last slide, please? So can I just close off this part of the presentation then? And really it's to say that Hywel Dda, we work in a footprint. So we serve a community in West Wales, and that's been put under pressure by the lockdown. And the future prediction is for that service to actually experience further demands upon it. What we're experiencing in terms of the discussions I've had with alcohol liaison nurses is bigger caseloads, patients coming in younger, advanced liver disease, and numerous problems. So often the alcohol is part of other things as well. So it clearly will take more time to work with those individuals as well. So as we move forward as a health board, we've got to be mindful of these challenges. And I don't think we're through the COVID pandemic situation just as yet. We need to think about sustainability of the current provision. That's also about the well-being of the staff that deliver the service. We have to anticipate future demands on the service, and also that high-risk group that I mentioned earlier on due to the consequences of the lockdown on other risk factors for liver disease. And at present, what we're doing is we're balancing those current demands alongside some proactive discussions about the future service. And probably, and this is where I'm looking to learn from this discussion today, I don't think we're unique in Hywel Dda. I suspect a lot of services across the UK will be experiencing this, and so it'll be quite interesting to hear other experience as well. And I'll stop the talk there, Chair, and I hope I've kept within my time limit.
Yeah, that was absolutely brilliant. Thank you, Dr. Morgan. And just bear with me a moment. Nicola has just popped something into the chat box. She wanted to raise the fact that working from home has been difficult for some of the new patients. And so, yes, so that has led to some changes, probable increases in patterns of alcohol consumption, which is a quite important consideration as we've all been going through this situation for quite some time now. Yeah, that's brilliant. Again, another really interesting segment. A few questions have come up in the Q&A box, but feel free, if there's any more questions, please pop them in and we'll address them at the end. Next, we've got Phil, who's our patient representative today, and he's going to share a little bit about his story with us today. Phil, thanks for coming. And can you just tell us a little bit about your journey with alcohol-related liver disease?
Sure. So I feel like the outsider coming in here. So it's really interesting seeing loads of experts talk about my condition, which is really fascinating. So I was a what you would describe as a fit professional. I like to drink. I don't think I consider myself to be a big drinker. I drank wine primarily, so I didn't drink spirits necessarily. But I enjoyed a good, like what they call a liquid lunch, I guess, and was out with friends and never thought twice about it. Now, as it turns out, I was drinking probably a lot more than I thought I would do, which I think is part of the problem people don't realize. It was interesting talking about units before. I don't think they really know what a unit is of alcohol, actually. I don't think they know what a large glass of wine is, for example. So I was, a fit working professional. I was slowly turning yellow, which your speakers have talked about today. I will talk in what they call lay terms. I'll talk about as a patient as I saw it. So my stomach expanded enormously to the point where I thought this isn't right. I got a GP appointment. I think it was probably in about 3 to 4 days, which was partly my own kind of consideration, which is, oh, well, I'm sure it's fine. It's nothing. I'd come back from holiday. So people were going, hey, you look well. You've really caught the sun. Not understanding that I was turning yellower and yellower by the day. I checked into the GP, who said, well, I think this probably looks like a case of cancer, given some of the family history you've got, but we'll get you into A&E quite quick. I went into A&E, and it was a story of two tales, really. One which was, the first one was, oh, here's the drug addict alcoholic that's arrived in reception, and you must have been here before. And I'll be really honest, I'm in my early 50s now. I've never really used the NHS in my life before. I've never hardly ever used a GP, and there was quite a lot of bigotry, and I was quite shocked, if I'm honest, that I suddenly felt, oh, am I just some kind of weird alcoholic drug taker and didn't really know it. When I got up to the specialist unit, it was a completely different story. I connected with the Liver Trust. I started to understand what was going on with my liver, but it was quite a lonely journey. And actually, I nearly died, and effectively my liver was failing really, really badly. And yet I did not consider myself to be a heavy drinker. So in summary, it was turned yellow overnight, got admitted into hospital, and nearly lost my life. And now I obviously don't drink at all. So that's my quick story in a pocket in 5 minutes.
Was it a shock, do you think, to be diagnosed with alcohol-related liver disease?
Absolutely. I mean, it's not something that I'd come across, I'd read about necessarily. The liver was something that you kind of hear about, but it's not really, I don't think it's in the public eye very much. And also, I think if you're surrounded, I mean, there's a lot of talk about, alcoholic help and all the rest of it. I gave up like that. I didn't think twice about it. It was sort of a, well, do you want to live or not? And it's gone. That I've never touched alcohol since. But when you talk to people about alcohol, I was surrounded by people, all professionals, having long lunches, drinking loads of wine at lunchtime, going home, having a glass, who never thought twice about it. So I think if you're surrounded in a society that actually is drinking as much as you are, you don't actually kind of think it's odd. And actually, I know I spoke to you previously about this, which is the biggest prejudice I've had since I gave up drinking has been about giving up drinking. And we live in a society where, the consumption of alcohol is considered so normal that if you go outside of that norm, you're considered slightly odd, I have to say. So the prejudice I've had has both been about alcohol, but increasingly about not having a drink with lunch or, and I was never drunk. I mean, I was never, people say that and people go, yeah, right. But actually, I put people in the taxi at the end of the night. I was not your typical falling over, hey, not involved in domestic violence, not involved in any of the things you would typically associate with alcohol. And I suppose for the medical profession, that's a bit of a challenge because I think there is a lot of people out there who don't tick all of these boxes that you may think, alcohol, it's got to be that. And actually, very often it isn't that at all.
Mm. There's two sort of things I want to try and pick up on there. Yeah. So first of all, so earlier on you're saying you're sort of a fit professional person. Yeah. not your sort of stereotypical person with a drinking problem that we might think of. So yeah, were you treated differently, do you think, in hospital because of that, or by friends, families, or?
I think there was a range. So I think when I checked in, I was treated, and I hate saying this because everyone's got their own issues. So it sounds as if I'm sort of saying, oh, you people over there. And I'm not saying that at all. I suppose what I'm saying is that there is a certain assumption that when you check into a casualty department, that you are a certain, like, I mean, they tested me for alcohol and couldn't find any, for example, which really threw them, which is, well, have you not had a drink this morning? I think I was asked. I went, no, I think about a week ago. It was like, and they said, what? Well, there's no alcohol in your system. Well, we better test for other stuff then. And eventually it comes down to the liver. So I think, obviously, work colleagues generally were very supportive, got quite shocked. And I think it was, and this is not, and I hate actually saying this, I think the more, but I'm going to say it because it's, it's a seminar, that's the whole point of it. The more people thought you were slightly more intellectual than they thought you were, the conversation changed, which I think is really bad. Because actually this, and they went, oh, I think you know what, I mean, one person said, I think you know what you're talking about, so we can have a sensible conversation with you. And I was like, oh, so have I suddenly become qualified to talk about alcohol? So I did notice a change. As people realised I could have a sensible discussion about alcohol and also push back a bit as well, and sort of say, what does that mean? I mean, I have to be honest, I was a bit blindsided by the science. I have to be honest. I kept saying, so for example, someone would say, I think your liver's failing. I mean, this is the line that was said to me was, this is as difficult as it gets. This is as serious as it gets, I think the line was. And I had to put my coaching hat on to say, if 10 is I'm going to die here and 1 I'm not, where am I on that scale? And I think they said, well, it's 8 and failing fast, so you're heading towards 10. And I went, got it, okay, I get that. But these terms that were coming up, I just didn't understand. So there's probably a gap between assumed knowledge and what the patient maybe sometimes really understands about the liver, maybe.
That's a very interesting point, because in support groups that often comes up that the communication from health professionals is not always great, and not because they're being deliberately awkward or whatever. It's just the language. The language is very medically complex. Yeah.
And I have to say, I mean, just to reiterate what I'm saying here, my level of specialist help was exceptional. So the people who knew about liver really knew about liver, and I trusted them absolutely 100%. But I just had to kind of go, what does that mean? Am I going to die? Do I need to make a will? So all these practical things that, most people, it just gets in the way, doesn't it? But you did need to ask those questions. And there's a lot of assumed knowledge, which is, I think, where the liver trust came in a bit, because you start to explore what does A mean? What does B mean? What does C mean? And you suddenly start to picture it yourself. And there's a lot of self-learning, I have to say. A lot of self-learning goes on.
Great, okay. Again, you mentioned earlier about sort of work hard, play hard type scenario, and sort of going out with your professional colleagues, and you were all doing the same terms of having a drink after work or whatever. How has you now being diagnosed with liver disease affect that? Has it affected it at all?
It hasn't, because people are probably over cautious about making sure I've got something to drink. I think there is a confusion in the market about alcohol free, because I think a lot of people diss it. It gets a really hard time. And I accept some alcohol free drinks could be a trigger for some people. And I'm not saying it's right for everyone, because it might trigger people back to alcohol. But there is a certain percentage of people out there where having a glass of complete 0.0 ABV fizz, complete alcohol free, actually just helps with the social aspect. And I think personally more could be done with that. And I know the NHS generally, not just in Wales probably, but across the UK, is a bit nervous about giving that message out. And I get it, because it's, it could be a trigger for people, and some alcoholic drinks. I mean, I read somewhere that, don't have an alcoholic free drink. Somebody might spike it, was one bit of advice. And I was like, well, that's been true since I was 17, they could spike anything. So there is a sense of, I think the alcohol-free industry probably needs a bit of support and a bit of explaining to, what is ABV? What's alcohol by volume, for example? What is a 0.0 drink? Now, I'm not saying it's right for everyone, but the social aspect I don't think can be ignored, because just having a glass of complete, and I don't touch alcohol at all, but some foodstuffs have got alcohol in, which I learned about, certain types of orange juice, certain types of bread rolls, so there's a lot of education to be done about, certainly amongst the professionals who just like to go out and lunch. But people generally have been over supported. I'd say the catering industry is shocking. I've been made to feel like an alien in most places when I've asked for a choice of, alcohol-free beer, or, what choice have they got that's alcohol-free on the menu? I've had, are you mad? What's the point? So I think the restaurant and the catering industry is pretty poor at that. I think personally, my friends and colleagues have been really supportive. In fact, it made them think about their own alcohol consumption. So I know, two of my closest friends now have drink-free nights where they didn't previously. Just because they've gone, well, if that's right. You, that could be me. So we've never seen you drink that much, because you're all together. So you don't clock if it's a lot or if it's not, because actually everyone just order another bottle of wine. And I think my consultant said, we're talking about a French glass of wine here. The old-fashioned kind of small glass. Well, he said, he said you could have a large glass, and a couple of those, that's a bottle. We talked about ABV before. Sorry, what is a unit? People think that a large glass of wine is a unit, and we know very well it isn't. So there's a lot of there's a lot of depth that probably is needed, and how you communicate that, I'm not sure. But I do think alcohol-free drinks needs to be a bit more for people at the early stages of, thinking they've got to drink when they're out. For more choice, I think people will take it, and I think there needs to be more work on that. Great. An unpopular view, I'd say.
So that's quite a positive, positive support from people. I'm wondering if there's a flip side to that. Have you experienced so-called sober shaming at all?
Absolutely, 100%. I would say most of my sober shaming is the amount of prejudice I get. 100%. I think most people go, oh, you've got liver disease. Well, people make assumptions about what liver disease is and what causes it, which I think your first speaker, sorry, his name I can't remember, but he made a really good point, which is people, alcohol liver related disease is one of the smaller aspects, really important. But people just presume that everyone is, with liver disease is a big drinker on a park bench with a vodka bottle, as someone actually said to me. But if I ask in a pub for an alcohol-free drink, or I'm not drinking alcohol, you do get shamed. There is no doubt about that. In the population generally, there is a lot of what you're bothering with that for, and you are meant to feel quite left out. So it's a bigger cultural issue, and it's not. I'm not saying I've got the answers to that. But I think choice and more, more people having choices when they go out is acceptable. But yeah, you get sober shaming. It's massive.
What was? I've just got a couple more questions to throw at you. Sorry, Phil.
Go for it.
I'm just thinking, because a lot of this webinar has been talking about COVID and the effects of COVID on various drinking patterns and so on. What was its effect on you? Was it negative, positive?
I suppose it was, and I hate dissing the service I had, because I think it's really exceptional. I noticed a real wind down in the personal conversations. So, for example, I ended up being an outpatient, and so I'm an outpatient, and it went from being, we'll have a phone conversation with you every 6 months to check you're okay, as opposed to we'll see you in person. So what used to happen was they'd get my bloods. They'd have the bloods for the meeting. They would go through it, have the scan, and they'd go, yeah, we think you're on track, which I am, thank goodness. Now it's sort of bloods taken 6 months, and we'll chat to you in 6 months. So I don't know if those bloods are okay or not. I have to wait 6 months for that. So, I mean, interestingly, in the last couple of weeks, there was something I didn't feel well, and I did feel a bit kind of, but it's liver disease, isn't it? And even my liver, and this is my GP, and even my liver consultant was saying, no, I don't think it is your liver, actually. And I ended up going to casualty because it was like, well, it's liver disease, isn't it? And I was like, well, I don't think it is, actually. Just really, and I had to get all the tests in casualty, which again is pressure on the system. So I think yes, it has. I mean, when I spoke to you originally, I think I said I wasn't sure, and I was in between, and I've seen it get slightly worse in the last couple of weeks, actually, partly because I've had to call on some services. So I think there is a presumption, not with every medical professional, but there is a presumption that if you have got something that needs medical attention, well, it's liver disease, isn't it? And that has been particularly true in COVID. But the one thing I would say is that the injections I've had my injections early. I got my pneumonia injection. I got my flu injection. So the injections, I think, are 100%. So you got all the injections on time and early. If anything else that comes up that may be slightly not right, there is a bit of, it's liver disease. You've got liver disease, haven't you? So there's a bit of that goes on. But yeah, having a conversation is over the phone is not the same.
I've got one last question for you, Phil. What one piece of advice would you give to individuals who've just been diagnosed with alcohol-related liver disease?
I would say is you're not dead, and don't believe you're not dead. And I think I get the stats about, you know, in 50%, you know, you might be a goner within 2 years and all the rest of it. I think with some positive thinking, give up alcohol straight away. It's doable. Get friends around you who will support you. If alcohol-free is okay for you and you can do that socially, you know, get advice on that, get help, but don't be shamed. I think the way people chuck alcoholic around is just shocking. And I know that people, you know, who drink far more than I probably ever did would quite easily call me an alcoholic and drank more than I ever did. So don't be shamed, and don't make it who you are. You are much more than, you know, a liver patient. You're not an alcoholic. I would go as far as say that, you know, don't call yourself an alcoholic. Say you're making lifestyle changes. Don't, you know, I think a label is much more difficult to change for people than it's just, well, I've got liver disease right now and I'm working towards that. And yeah, I lead a very healthy life. You know, my overall my lifestyle is, apart from giving up drink, it has not really changed. You know, I still go out. So don't be intimidated by some of the prejudice that you'll get, because that will probably drive you to drink, if I'm honest, because it's stressful. It is, because I'm justifying yourself all the time. Don't justify yourself. Stand up for yourself and talk about it. And I'm quite bullish now. So if someone says, "Oh, what happened?" I go, "I've got liver disease," and then they go, "Oh," and they're quite shocked and they don't know what to say. And then we have a conversation about it, because I feel, you know, I think you feel a duty if you have liver disease to talk about it, which is why I'm here today. Because I think, you know, I think one person said to me, "Well, maybe you just need to sit in the corner and drink fizzy water." And I went, "No, I won't just sit in the corner and drink fizzy water. I'll talk about it." You know, and that would be the best bit of advice. You're not dead. You can lead a fulfilling life. Get the support you need, but for goodness sake, give up alcohol. It's just not worth it. It's just you've been told a lie about alcohol, and it's not true. It doesn't bring you happiness. It's just a social norm that will go out of fashion eventually, probably.
Fingers crossed.
Fingers crossed.
Thanks for that, Phil. That's brilliant. I could honestly talk to you for hours, but our time is up now.
Thanks for the invite.
So we're going on to the question and answer session. We've already got a few questions in the box, so we'll try and work our way through them. Okay, one question that came in quite early was, can you get a FibroScan privately without a referral? I'm not sure. Would anybody know the answer to that one? If I can bring the panelists back in, that would be great.
That's an excellent question, and we might just have to clarify that one, Sarah. We'll. I'm not aware of what that would look like in practice. So
okay.
Can we park that one and get back to the questioners subsequently?
Yep, absolutely. We will get back to it. But I would be remiss not to quickly mention our Love Your Liver roadshow in relation to that. Although this is designed to pick up alcohol disease where it's not suspected. So if you're under medical care already, it's unfortunately not appropriate. But we do have a Love Your Liver roadshow where we take a unit out and we scan individuals, do a FibroScan on their liver and do a screener. Currently our unit is in southwest England. More details can be found on our website, and we are planning to come to Wales early next year. But as for accessing one privately, we will have to get back to you. the next, more of a comment than a question, but I'm wondering, Dr. Morgan, if you've got anything to say on it. Denise from Barrowd has said that the service users through lockdown thought that the services were closed, and that's why they weren't accessing support.
Yeah, that's an interesting one, and I think that the whole COVID pandemic did create confusion about what services patients could access and so on. I think there was also a lot of fear about patients coming into services, thinking that if they came into healthcare settings, they'd be it more at risk. And I would also probably question information sources. I mean, we live in that sort of 24/7 world. There's a lot of social media. So generally it's best to sort of check the official advice. But I think it was a very confused time communication wise. And, you know, I was actually deployed to help with the COVID vaccination program myself. So there was obviously that focus within the health boards to deal with the pandemic, and possibly there could have been some better communication is the way I would couch that.
Right, thank you, thanks very much. Phil, there's quite a few comments in the question and answer box just saying, you know, great to hear from you. You know, it's important to share stories such as yours to raise awareness. A couple of questions around, would you mind sort of saying roughly how much you were drinking and what your sort of treatment you're having now and what sort of symptoms you still have now?
Yeah, sure. So I would think nothing about having a bottle of wine after work at night, and I would probably go out afterwards and have a couple of glasses with a meal. That was probably it. My consultant said it was probably more over time, which I think a lot of people underestimate. So I'll be quite frank. I've worked in the media business all my life, and he said he sees loads of judges and media people. I'm not sure what that says about media people, but yeah, I think it's longevity and parties and all the rest of it. So I think wine, you'd think nothing about having a few bottles of wine with lunch with friends. It's difficult to quantify because everyone was drinking. But you know, if I was on my own after work, I would think nothing about going and having a couple of large glasses of wine and maybe a couple more with dinner quite easily, and meet other people for a nightcap in a bar. It's just what you did. I wasn't drinking mornings. I wasn't drinking at lunchtime unless there was a work lunch. So it was definitely a kind of overtime thing. My treatment now is really I'm on a treatment to control the acid in my stomach to make sure that any ascites doesn't develop. And that's it really. My treatment is quite low. I think my positive thinking and my early treatment worked really well. So that is the amount of treatment that I have. I think the message to me was stay off alcohol. That's the best treatment you can have.
Great, thanks Phil. There is a question, Nicola, I'm not sure if you're still having problems with your mic. But if you could answer, if you can't put your mic on, if you could type something into the chat box and I'll read it out. But the question is, what is the difference between a FibroScan and an ultrasound scan? And I will come back to you on that in a moment. And I shall just see if there's any other. Okay, so one question has come in. Again, I think it's for you, Nicola. Patricia has said that she had hallucinations after giving up alcohol and was given diazepam and guided to DDAS. But it was never suggested that she get LFT blood tests or anything. So shouldn't GPs, etc., be encouraged to direct you to get such a test as a way of identifying liver disease conditions earlier? Okay, so that's actually quite a tricky question, Patricia. If Nicola is able to type something into the chat box about that, that would be great. But from the British Liver Trust point of view, we are working with GPs and other health professionals to improve on the pathways. Wales has recently published a report on pathways in Wales, and published a lot of learning that other countries within the UK, so England, Ireland, Scotland, can hopefully learn from. But yeah, people don't always get directed straight to having appropriate tests, because it's so difficult to identify, as there are no real symptoms, no obvious symptoms in the early stages, which is why it's particularly different illness to deal with. Okay, so going back to the fibroscan and ultrasound scan question. So I think from what's been typed into the box there, an ultrasound scan can actually look at the liver, but a fibroscan doesn't see the liver. It actually gets it indicates a level of fibrosis or scarring. So, and that can sort of indicate how damaged or not the liver is. Okay. This is a good question from an anonymous attendee. So screening has been mentioned by all panelists. Is there a single method used for assessing medical outcome and giving the individual an ongoing indication of how they're doing, good or bad? Unfortunately, as Nicola is unable to come on the mic, unfortunately, and Dr. Rees has had to go leave us because he's got clinic. It's a bit difficult answering the medical related questions at the moment, unfortunately. But from my non-medical understanding, there's a lot of tests and investigations that build into a bigger picture of if you have liver disease, and if so, what stage is that, and what type of liver disease. So there isn't just one test. I believe, yeah, I would just like to mention one more thing. Thanks for the prompt, Rebecca. If you do have questions around the medical side of things, you can contact our liver nurse helplines run by qualified nurses, and they can answer lots of questions around terminology, different things. They can't diagnose you specifically, but they can talk to you about different things, but can't diagnose. So that'll be great. And that is it. I would just like to do a little reminder about support groups that we run. We run a lot of support groups for a range of liver conditions and in lots of different areas. We also have a specific support group for those with alcohol-related liver disease. And of course, we've got the nurse run helpline that I've just mentioned. Our final ask is to work with us to tackle this problem. It's going to be a combined effort with the NHS, third sector organisations, us as the British Liver Trust, substance misuse organisations. We're all going to have to come together to try and tackle this issue. So please feel free to contact me or anybody here if we can help in any way. And that's it for now. Thank you for attending today. Have a great afternoon and goodbye. Thank you.